Yeah, but mute's there and I don't know, it won't mute it. Cause some people are like, we can't hear anything. And it's,
Because that is.
You're like, sign me. The system says you're a minor, hey, turn your light in. I get like, I don't care till they turn this shit in. But
oh, we don't have a flag
so
back there.
Oh, yeah, but they have paramedics too.
That's something I wish I had more. That, turn shit in, or was that reminder? If I see reminder.
PSVT stands for pulse less supraventricular tachycardia. Attached to the drug cards provided to my partner from the instructor. And they don't know.
So we're sure.
They will fail.
Oh.
Call it. And so,
Now, this is good. I was like,
the tip of the iceberg. It's
Yes, totally.
Okay.
Louis.
March 2026 meeting of the Indiana UNS Commission report. And we spent
Hi, just in time. All right, this is the funny thing. Yesterday, 2 days ago, only these.
Sorry.
Did you get there?
Lee Turpin,
Just in time.
Darren Hoggett,
Present.
Dr. Lisa Clooney. Present. Patrick Hutchison,
Present.
Matt Shady,
Here.
and Jerry Harder is out today. John Zartman,
Present.
Dr. Sarah Brown,
Present.
Matthew McCullough,
Here.
Andrew Bowman,
Here.
Mary Ann Dudley,
Here.
Dr. Jim Nossett,
Here.
Lori Bailey,
Here.
and Dr. Eric Gable. I don't see him online either.
I just jumped on 2 seconds ago. Am I approving something?
Oh, there you go. Just say nay.
You have four.
Yeah. If we could all please stand. Pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. I'd like to welcome everyone here today, and we will move to the agenda. Do you have anything that starts with you this morning?
The only thing I would say is, Nate did inform me they sometimes do publicity things, so they may come through and take pictures. So there is a lady taking pictures, then that is why, not a terrorist attack.
Moving forward, adoption of minutes. Pleasure to see. Thank by Commissioner Nossett. If a special or change is needed. Okay, you want to call it?
Yep. Lee Turpin,
Aye.
Aaron Hoggett,
Aye.
Dr. Clooney. Patrick Hutchison,
Aye.
Matt Shady,
Aye.
John Zarkin.
Aye.
Dr. Brown,
Here. Hi. I am still here.
Matt McCullough,
Aye.
Andrew Bowman,
Aye.
Mary Ann Dudley,
Hi.
Dr. Nossett,
Aye.
Lori Maylee, Dr. Gazel.
Aye.
And it's approved.
Adopted. Moving on to honoraries and certificates.
As you can see, this information only, the stroke awards and cardiac arrest states still are very popular. We issue a lot of those. The only, the individual awards I'll highlight would be, we announced that the last commission meeting, as I recall, the line of duty death passing of Jake Amos. And we did give the EMS Star of Life, and it was presented during the funeral service.
Now moving on to evidence. Any Department of Health, problem system.
So,
Should have a remote.
all right, all right. All right, so thanks to the EMS Commission, everyone, for having us here today. Just, I'm going to give some quick updates from Division of Trauma and Injury Prevention. It's our mission, our vision. Something much different than anyone else in this room here, that we just want to make sure pictures are safe and healthy for us. Want to do a quick update from the Regional Health Transformation Program, in particular, the initiative number 1, which is the MOC, the Medical Operations Communications Center, Coordination Center, pardon me. So just to kind of give you a brief update on where we're at with that right now. We are looking, the RFP that's going on for the, I kind of labeled it the technical components. So looking at patient tracking, hospital boarding, bed capacity types, some of the minor details are still being worked on what it's going to exactly do. Probably more than one vendor, but that RFP is, if it hasn't gone live yet, it will be very soon, potentially next week. So then we'll have some more information on the next meeting about what we ended up with there as far as vendors. The executive steering committee has been put together, still been probably finalized here and there, but ideally, some of the things they're working on right now is we've invited Texas and Oregon to share some of their works that they've done in the space with that group of folks to just kind of get a better sense of some of the initiatives, some of the pitfalls and good and bad that they've gone through. Texas, in particular, talking about Southwest Texas track. So anybody who's been in this space looking at doing any research in these mocks has probably heard of them. They're very mature, very advanced systems. As a matter of fact, we know the size of Texas. Their track is the only one in the state that works and functions at the level that it does, which is pretty high functioning. They are 25 years mature, so we know we're not jumping into that right off the bat. But we've been able to build a good camaraderie and kind of teamwork approach with them to help kind of feed information back and forth. They review documents and whatnot. And so they've been a good player. Oregon's newer in the space, different kind of approach. So it's nice to hear how they're looking at things. And theirs is more of a university based, not state based. So it's just kind of interesting to see. We continue to socialize the concept and the plan with the steering committee. And as we do that, working on a more comprehensive communications plan that we use more mainstream. So when we talk to groups, not just the EMS Commission, but anywhere outside, we're trying to make sure that folks understand what we're doing, approaching stakeholders and looking at sustainability through different hospitals and whatnot. We have one unified message. So that is continuing to be put together. And then the scope of work for the actual mock development is being finalized. We need to continue to have meetings weekly at this point, really, and just kind of trying to nail down before we put the RFP out, and which now is looking like April or May. So we're hoping what that's going to do is we're going to have that group, a team, business, whatever it may be, that hopefully has some experience in this space and will help kind of drive and literally build it, physical mock, what it's going to look like. So all still in the infancy, but at least I have some more direction than last we spoke about it. So I'm happy to share that's kind of where we're at with mock work. I want to take a brief moment to, I know I shared, I think at the last meeting with this group, that we still have funding available. Our RFA remains open. So those are typically larger projects. There's a link, I'm sure you'll get the slides that'll take it to our website where you can apply to the official application if there's anyone interested. The key strategy areas are listed. And then also for FY 27 track funding has been renewed. And they're actually, the tracks are going to receive more funding than they received for FY 26. So for those of you that have already benefited from it, you realize that we put a lot of effort into training and even equipment needed for frontline providers of pre-hospital space. So that will not change for FY 27. That's why I want to make sure this team and this group knew we continue to support EMS and pre-hospital through our tracks and through the trauma trauma development. So that's good information to share there. I want to just, again, remind the group about the CARES registry, the cardiac arrest registry. This is just a quick slide so that we had something on the books to show you. The main thing I want to point out is Moses Barrio, his contact information is listed here. If you have any interest or want to know more about it, he is open and ready to go, looking to enroll more, anyone who's interested. So please reach out to Moses if that's something you think you'd be interested in. And I wanted to put this up here as just a brochure, but if you're interested, I think Moses can provide some brochures if you have folks that are just looking for more, want to help kind of spread the word. So I wanted to share that with the group. And some quick other updates that are coming out of our division. The coroner's case management system, they have a new case management system called Hero. I don't know how relevant it is to a lot of folks in here. I have met some people that are both EMS and coroners, so I wanted to make sure we shared it with the group. The North Track. So if you're in emergency preparedness districts 1 through 3, Nicole Raylander has asked me to reach out to you and say, please reach out to her. She is not had this great communication with some of her pre-hospital there as we've had luck in the central and the southern regions. So she can work with you, talk about different ways to fund initiatives, partnering. She's doing a lot of good work between LHDs and hospitals. We're trying to build relationships and kind of knock down some barriers so that people know who's in the space when we're talking about taking care of Hoosiers and putting some, fortunately, we have some funding to put behind that too. So if there's initiatives where we can work, if it's pre-hospital and LHD or pre-hospital and hospital, whatever it might be. If you're in preparedness groups 2 or 3 and you have any inkling of maybe it's something that would benefit from funding, or if it's trauma related, Nicole is your contact and she is very willing to talk to you. I'm really excited about this next board. We continue to plan and we have gotten much further than I expected as quickly as we have for cadaver labs. It's been a huge, I've not heard ever one person say it was a waste of their time or a waste of funding. And we've done a ton of work this past year. If anyone in the listening or in the room was at Johnson County's cadaver lab, it was an awesome experience. Andrew Bowman was there. I don't know if we'll be able to replicate to the extent that they did there, but we're looking to take a lot of that and put it on the road and go to different areas. So right now we have some interest in the north, central, and the south track. So we have the state covered, but we're trying to get east to west, rural, urban. We want to make sure our paramedics and whomever, right? If we're talking rural, it could be a family boarded emergency medicine physician who maybe have their hands in it as deep as some of the ambulatory or the more busy hospitals if they're critical access. They're invited, respiratory therapy is invited. It's really just anybody who's going to be taking care of these patients in a trauma situation. We want to make sure. So we're working with Eric Yazel, who's on the line, right? Dr. Tim Pullman, who's a trauma surgeon, has helped kind of put some curriculum together behind this. So really excited. If you think you have an area or someplace that could benefit from this, I would say don't hesitate to reach out to your regional clinical coordinator or myself. So again, right now we're in a great space to have some funding to support these initiatives. And this is the kind of training that a lot of these folks don't get hands-on. I mean, it's much different when you're doing it on a cadaver than with a, plastic mannequin or whatnot. So, and it's not always the most affordable for a lot of places to do. So that's why we're really trying to take advantage of this opportunity and get as many hands-on experiences as folks as we can and that are interested. So that's awesome news, and we'll continue to share that throughout track meetings and whatnot as we develop those and have them hard timelines. And then BDLS and ADLS. BDLS has been on the pre-approved education, which just means it's really easy. Anyone who's taken it can submit for it. It doesn't have to go through a committee for approval. ADLS now, through all three tracks, is now also on that pre-approval list. So, and just looking at ways to get people prepared. So, just going to share some upcoming meetings. So our Trauma Care Commission meeting May 1st, and then the subcommittee meetings there listed. Always, if people are interested in that, please reach out and let me know. That's all I have for you today. So if there's any questions, otherwise I'll turn it back to the group. Okay. Thanks everyone for your time. Have a great weekend.
Any questions? Okay. Hearing none, moving on to legislative update.
The 2026 legislative session is over and it ended on time. I reviewed, there was not really much on EMS. The boards and commissions, the Bill 1003, it was passed. Initial legislation did not impact the EMS commission. There was an amendment that added on the House side. On the Senate first, what this means is this commission adopts a rule. People do criminal background checks for initial certifications only. That includes through Indiana training programs as well as reciprocity. Now, all those people will have to have background checks. In the past, we had the rule, but the FBI, if you use their result, then police can only release it to approved authorities, and they would not approve our office. They say you have to have a state law, and they would not recognize the rule. So that's why we now have a state law. So now we have a rule and the law telling people they have to do it, but we also should be able to gain access to do those background checks. So for me, I think that was a little bit of a quiet thing. I don't even know that it's ever addressed publicly in committee. But that's a big win for EMS as a profession and as clinicians, that we were, I believe, the last one that did not require background checks. And so I think that's going to be a positive win. We do ask questions, so I feel like we were vetting, but this gives us more regulatory authority to do so. House Bill 1251 covered emergency services for counties and in underserved areas. It passed the first committee and it passed the House side. When it went to the Senate, it passed a committee, but then it was sent to a budget committee and it was not a budget year. And so it died in that committee. So I did see Representative O'Brien, who has been supportive of EMS. I believe he will want to continue to pursue that dialogue because he is very vocal and supportive of making sure that every resident in Indiana has access in their communities to emergency medical services. Those are all the legislative updates I have, unless anyone has it.
Any questions for Drew? Hearing none, EMS for Children, Margot Cook.
We are very close to sharing Indiana Hospital Pediatric Ratings Project data. I'm waiting on those to be approved, so I don't have anything today, but hopefully our next commission meeting will be able to share our ALS report as well as our BLS report. That was taken back in 2024. I will be attending all of the district forums. I think Craig is going to share more about that. We do have on April 28th at Hendricks Live, it's going to be the Riley Trauma and Burn Symposium. Registration is now available for that, but Drs. Howe and Dr. Weinstein, Dr. Ferris are presenting, as well as Dr. Kate Remick. She is the lead of our National Resource Center. We're talking about pediatric readiness there. And that's all I have.
Thank you.
Thanks.
On to Indiana Fire Chiefs Association, EMS Chief Harris.
He should be online.
Yeah, I'm online. Say the date as you see up there. Last month we had a really good tech and data symposium up in Noblesville. Had a good turnout. Lots of good things to learn about technology and fire and EMS. And if you didn't make it this year, try to get there next year. And don't have anything else. Have a great day. Have a good rest of the meeting. And if you have any questions, let me know.
Questions for Chief Sykes? I'll add to that, just on the EMS side, we're going to be going to Washington DC next week to speak with legislators about state and federal issues. For the EMS side, some of the things we'll be speaking to them about is reimbursement for EMS treatment in place, expanding the grant programs for community care events and the mobile integrated health, ensure that the fire-based EMS providers are counted in the Department of Labor statistics. Right now, we're not. And helping reimburse EMS for pre-hospital blood administration. So that's some of the hot topics that we're going to speak to legislators about for the EMS side. And University Medical Services Association, Tom Pickers.
Good morning, everyone. Thank you for let me take a couple minutes of your time. Just want to kind of give you some updates on things we've got going on right now. First one we like to talk about is we have our Run with Shears coming up May 16th. That's going to be at the Indiana State Museum lawn, downtown Indy. It's a 5K, run walk, or a virtual 5K if they can't make it. We also do a kids dash. The cost is $35 in person. You can also do the virtual option, which is also $35 as well. But remember that the price will increase on May 5th. $5 for the kids dash. We usually kick this off on May 16th because that is the Saturday prior to EMS week. So we just want to promote EMS as much as possible during this time. And that money does go towards the memorial. So we're raising funds. We hope to have that completed this year. That night is our Golden Sirens dinner. We have a joke right now that we're going to start calling this the Golden Shears weekend for both of them, so that everybody just goes to both. We're going to have that again at Primo Banquet Hall in Indianapolis. General admission for that is $40. You can get your tickets online at our website. If you have a provider and they want to go ahead and purchase a full table of 8, you can do that as well. We also are encouraging sponsorships if needed. There'll be a QR code. We had them on PowerPoints, and we'll have them out on the website and social medias later on today. The last one I want to talk about, as one of my biggest pushes, is our conference is coming back this year, bigger and better than ever. It will be in November again at French Lick from the November 18th through the 20th. The reason why I'm telling you guys this so early is because we do have abstracts are still open. Abstract presentations. Now, I will say, if you have applied for an abstract and you can't apply a second time, we did find a snafu in our new system, registration system. Please email me your second and third, fourth, fifth, whatever amount of presentations you would like to do. Follow the same format, or I may email you back with please send me this many things so we can get your CE approved. And then if you have any questions, please feel free to reach out to me. I thank you for your time.
Go on to Education Oversight Committee. Commissioner Sark.
Good morning, everyone. As you guys will recall, we presented 3 elements last commission meeting, and we took that back with recommendations that the commission wanted to look at. The first thing I'd like to talk about is the EMT competencies, so the SOCs. One of the biggest things to remember here with that is this was a document from the National Association of EMS state officials, and it kind of encompassed the NES standards and so forth. And some of the research that we did on the numbers, we believe that their recommendation from the numbers came from COEMS. But we can't totally confirm that, but we believe that. If you go to the next slide. So if you remember, we proposed that we wanted to do probably 20 tools. You guys felt that, asked the question as to why were we modifying what the recommendation was from that document. And a lot of it was that the age group and the control numbers, we lessened a little bit, for the fact is we were concerned about the rural communities and be able to get the EMTs in for the clinical sites and so forth. So when we originally, I believe the original thing was we went with 20, which was 10 more than what we currently require now. Right now, we don't require any breakdown within the age group, and I believe we went with 10, 5, and 5. The proposed from the SIMSCO was the 15, 9, and 9. Where our discussion came into play was, what is a pediatric patient? Okay? Because their age group goes from 0 to 19. And the group felt that 19 was a little high. And so we researched that to find out numbers. So looking at American Heart Association, looking at the NES, looking at some of the sub-forces like National Association of EMTs with EPC and PEP and so forth, it's all over the place. So, you know, we are looking for a little guidance, which you feel the pediatric age group should be, but we kind of felt, the group felt that 19 was a little high. So just kind of a little discussion maybe from the medical directors. Some of the people that are, 12, 13, 14, and 15, they're sizable adults. So what is that magic number is kind of where we're stuck at. And then the other aspect of it is do we use what our current requirement is 10, or do we go with mid and go with 20, or do we take the 30? A lot of people, a lot of providers feel that 30 is kind of a high number for getting a large amount of students through different clinical sites. And I'm open for discussion on that.
Well, from an age standpoint, for some reason, I'm always stuck on the age of 14. That's almost random, but so some 14-year-olds are bigger than most of us here, and some 14-year-olds are pretty tall. So you never know. But it seems like a good spot to land on. No data to support that whatsoever. Yeah. So.
I mean, 19 seems pretty high, but I mean, it is random. Do you go by 8, which is not here, so random.
We could easily argue the geriatric version as well. Is 65 really geriatric or should it be
No.
70 or?
Okay, so one of the things, that Director Kenny, and Chairman Kirk and I have talked about, Craig has got it set up, so there's PI meetings, that, Terry's going to be doing the next couple of months, so we thought we would, ask during that time frame, what some of the providers feel, and then we will try and have a recommendation for you to present to you at the next commission meeting. We will be meeting again next month. Commission.
Half of those can be with the end.
So, yes,
Is that-
so that was, thank you, Darren. That was another question, and we decided that, yes, it is highly recommended to try and do all live. However, the other way we presented the last time, that it would be with high fidelity mannequin, and we felt that, especially the pediatric stuff, it can be done by mannequin, just general mannequin. That will probably be in that recommendation, it can be done by mannequin also.
I will say that, if you have an older pediatric level here, like 14 or something like that, your chances of getting live kids are better than if you take it down to 8. How many runs do we really have 8-year-old? Not that many. So it's a big difference, but I think it helps.
Yeah. I think a lot of it, just like we talked, a lot of it comes down to common sense, making sure that, we've got the appropriate mannequins to be able to check that out. The new revised psychomotor exam. So one of the things that was decided on by the group was the skill, the medical scenario, and the trauma scenario with an open age group. What I mean by that is, so we encompass the pediatric aspect of the state. When they send out that exam, they will make a choice of what those scenarios are. And it could be you have a trauma pediatric scenario or an adult medical scenario, vice versa. You could end up, it's just kind of random how that would be selected. The second part of that is we went ahead and formed different work groups. And with that, we have the work groups are in 3 different phases. One is scenario writing. The old scenarios that we have, we're going to take and modify so they're not exactly the same. And then developing some new ones. And that will be an annual event, kind of working throughout that whole process over and over so that nobody gets stagnant on the different scenarios. We are also going to be looking at the committee looked at the actual patient care rather than evaluating isolated skill sheets. So the skill sheets are being modified. It's going to be kind of designed like what we use as the out of hospital scenarios to also include into the oral wards. So this test will be designed so that it will be mainly with live patients, if all possible, and there will be some interaction. So because it's a basic EMT level and their assessment skills are going to be somewhat limited, a lot of it will be verbal. That's where the oral board side comes into play. And then some of that will be where they'll actually have to perform the skill, mainly vital signs. So they'll actually have to take a patient's blood pressure and so forth. Beyond that, we probably will not use some of the other aspects from the current discussion anyway, of doing any splinting or any of those kind of things. Those will all be verbalized things. So that's kind of where we are with that. We are doing some surveys and so forth, and the grading criteria. We hope to have that all submitted for you by at least mid-year. And we work very, very hard on getting that done. There's also a fiscal impact that we're looking at that to any kind of cost. We believe it'll be a decrease in cost for the training institutions. For the actual provider, it's really going to be up to who or the candidate. It's going to be up wherever they take that test, what that charge would be and so forth. But we're trying to finalize and get some of those numbers together. So And then the third phase was our advanced EMT cardiac monitoring. That has turned into great discussion. A lot of different things, going different roads, and so forth. We're trying to pull that back in. One of the things that is being done is Craig is set up with a company, and I believe his name, Delinea. We work with them developing some test questions, both for medical directors, the providers, and also the advanced EMTs themselves. So those questions will be going out soon. As soon as it gets finalized, we'll pull that data back in, and then we'll present that data to you, what the outcomes of the surveys was. The thing we are also looking at is the fiscal impact on this, because this will be significant, depending upon which way you as the commission decide to go. So we're going to try and have that proposed both from the provider level and also the candidate level, and most importantly, at the state level, because if we do this, we've got to figure out what kind of transition there is there, either all or none, or what that cost is going to be, for that kind of testing, because at the national registry level, they don't have specific testing over the criteria of the cardiac monitor. So that's kind of my report for now. There's nothing here for any kind of a recommendation at this point in time, just kind of an FYI.
Good questions, Commissioner Zarvin. Moving on to Mobile Area Health Committee.
We met on a month ago, Friday, February 13th. Subcommittees continued their work, and we basically, what we did there, we did not have any programs for consideration. We did have a nice presentation from Anthem on their Pathways program and on how they can connect to MIH programs, and that's kind of started an offline dialogue that our staff continues to have with them. Our next meeting will be on Friday, April 10th. As I said, the subcommittee did not consider any applications, but one of the positive announcements that I wanted to have was, as you recall, the legislature did not fund the Mobile Integrated Health grant that's in statute with the commission, but we had EMS readiness money that could be used for MIH. And so we offered what we call a companion grant that's based on the commission one. We did our first cycle for $500,000 early last year, and we have money left in the fiscal year we needed to spend. And so I will update you on amounts and things coming up. But as part of that, we did a new application process. And when we apply, you have to be an approved program or apply to be approved at the same time. And we had 2 credible applicants that applied to become programs and applied for a grant. We cannot award them the grant, but we would like to award till we determine they are approved. So what we're asking the commission to do is skip. There's no statutory requirement to go through the subcommittee. We're asking to skip that review and for you to directly review today and make a decision on approval. Staff has reviewed, and we believe both are appropriate. It's not really, as you recall, the main standards are that they have to be community-based and they have to be an EMS provider organization. And so really it's not, it's almost a registration. But with that, I will turn over to Emily, who is going to present on the 2 applicants that we would like, the staff would like to recommend.
Haven't hit it yet.
Oh, yeah.
I just wanted to confirm.
Yep.
Okay, so we do have 2 applications to review today. Our application process hasn't changed. That is still the same. You can find it on our website. It is just a smart sheet form to fill out, super quick and easy. The application requirements are also the same. So the 2 new applicants that we have this time, we have Benton County EMS and Porter Memorial Health, Porter Memorial Hospital EMS. I'm sorry. So the first one that we're going to review is Benton County EMS. They're located in District 4, specifically covering Benton County. The initiatives that they have selected for their area are the hospital dismissal, post-response follow-up, diabetic counseling, chronic disease management,
They're wanting to decrease their EMS utilization by their high frequency patients and tackle substance abuse mitigation as well as mental illness mitigation. So within their application, they had described their broad goals as they would like to offer more services so that they can curb the extensive use of their EMS services. They really would like to address their healthcare gaps that involve not pre and post hospital admission, their diabetic care, falls and services for, they have a large migrant population as well. So they're wanting to, this will be in coordination with their outreach services, which include their local pharmacy, local health department. Their local health department does have a vaccine program already in place, as well as developing further outreach within their local veteran center and their underserved populations. So their specific county, they did provide some kind of nice areas that you can see that, you know, they didn't rank super high in, but they're also very vulnerable to put these out there. Their specific county ranks 73rd in mental health provider access, as well as 84th in physician access and 85th in hospital access. So kind of lower on the access scale when it comes to what their patients have available. Their program is seeking out their best training avenues for a county of their size. They would like to send their staff to the NAMI crisis intervention training. And when they do have availability, that's when they would. Do we have any representatives for Benton County that would like to elaborate on that? You're more than welcome to come here.
Our program is kind of a follow-up of something we started pre-COVID to address frequent flyer abuse, outreach, and try to correct some of those issues that we had that were underlying since the post-COVID era. With the advances in my age in Indiana, looked at several years while the state advanced programs and the grant fundings that were available. We tried to see where we could create a small enough program for a county our size. We provide services to about 8,600 individuals with our geographic footprint. So I tried to write the idea of the program and the grant to a small program with a big impact, only because our run volume isn't as extensive as other counties. So with that, like everybody else, we face the same challenges, mental health, substance abuse. And so hopefully working with a New Veterans Center, our local health or drug coalition, those are some of the areas that we just have a big gap because of location. So we're 35 miles from any major resources that exist for any of those. And so with the NAMI crisis intervention training that offers all aspects of that, our hope is to hopefully bridge some of those gaps, work with some of those individuals that we get to see for law enforcement encounters to try to see if we can improve those areas and maybe ease some of the stress on our EMS system, but also create access for the individuals.
Good to see you here this morning. As your former EMS neighbor to Duke County, where my career started, I'm familiar with the hardships that Benton County faces. Have you given any additional thought to expanding your program to include, since there's no hospital, OB services, maternal, peripartum care to those high-risk individuals?
And when I submitted this, that was an area, even after Dr. House's presentation and discussions of that, it's definitely an area that I think we're open to, because that in our area, even for our patients that go to Illinois, that gap has gotten bigger in Illinois also, not even just on our side of the state. So definitely that's something that as we can pick up that information, get the training, try to figure out where we can have an impact, definitely because of the shortage of those services.
We'll move forward then. So our next program is Porter Memorial Hospital EMS. They are located in District 1. They will be covering Porter County. Their initiatives were hospital dismissal, chronic disease management, decreased utilization by those high frequency patients, elderly management, primarily falls, and immunization and vaccination initiatives. So their broad goals are they want to reduce those hospital readmissions. They really want to, especially within the post-surgical and chronic disease patients, they'll do this with a scheduled follow-up and monitoring services. And during those follow-ups, they already have a home safety inspection plan, as well as provide assistance with home medical needs and those supplies that could be lacking. The providers are required to be in good standing with company education standards, as well as looking into training 3 of their clinicians to obtain the CPC certification. Did we have anybody from Porter Memorial that would like to say anything?
Morning, thank you. So this is actually a journey that started 6-7 years ago, just prior to COVID. At the time I was working with a couple of hospitals down in Texas that had programs established. A sister hospital at the time, Commonwealth in Pennsylvania, that was very integrated and had a very successful program. COVID hit. Obviously, we kind of put things on hold. We didn't want to do things just because there was availability of services or funding. We wanted to make sure that it was sustainable. And we are at that point. Since putting in for the application and the work getting around in the county, I've already had people contacting me from Porter Stark, wanting to know if we could expand this into the mental health, as well as some private agencies that do outpatient care that want to know if we could follow up with their patients. So we would like to expand this and make this sustainable. Any questions? Thank you.
Those were my programs.
So as I indicated, the recommendation of staff is to approve Benton County Emergency Ambulance Services and Porter Memorial Health EMS as approved providers and skip the step of the MIH committee review.
Motion to approve. Second. Commissioner Zarvin, motion second by Commissioner Hogan. Any further discussion? We have a motion on the table to approve. Call the roll.
Lee Turbin,
Aye.
Aaron Hogan,
Aye.
Dr. Clooney. Aye. Patrick Hutchison,
Aye.
Matt Shady,
Aye.
John Zarvin,
Aye.
Dr. Brown. Aye. Matt McCullough,
Aye.
Andrew Bowman,
Aye.
Mary Ann Dudley. Aye. Dr. Nauset,
Aye.
Lori Bailey. Aye. And Dr. Gazel.
Aye.
Moving on to new business. First off, the overall policy, the large license.
One of the downsides of commission is it tests my voice by the end of the thing. I'm positive I can get up every now and then. Get up and move around a little bit. So this first order of business came about with Commissioner Hoggett, reached out. Someone was speaking to him about DNR devices, do not resuscitate devices that we have in Indiana. Oddly enough, when I went to law school, that was my senior thesis, was on Indiana's laws. And one of the recommendations was that we should have devices, because when I did that in 1993, we did not have the recognition of devices. And so our law does recognize devices. And therefore, you know, if the person has on a bracelet or a necklace, then EMS can honor those. Now, where we run into a challenge is what the actual law says is it says the actual devices have to have three things: the declarant's name, declarant's date of birth, and the words "do not resuscitate." But it also says Emergency Services Medical Services Commission shall adopt an identification device. And so for decades since then, we have basically said, if you have those three things on it, then it is a device in Indiana and we will recognize it. But that is just kind of a general policy office interpretation. And so I did speak, and so I guess I spoke with legal, and their recommendation was this non-rural policy, and our general counsel, Sean Wooding, is online. You can answer any specific questions you might have with that, but we had discussions. And I do want to cover, could the commission adopt your own device? I would say yes, with an asterisk, because the challenge is the way Indiana's procurement system is, you can't really have a preferred vendor. So you could not say so-and-so. The main way you could select the vendor is if you were actually buying the devices. And since we don't have a budget, then we are not going to buy devices to hand out. So really our only option is to decide what we will recognize. And so that's why we would like to kind of put it in writing, adopt our first non-rural policy of 26. That would be addressing that statute, covers the actual statute background. And basically it says that we recognize and authorize any field clinician to recognize medical DNR identification device, regardless of vendor, that meets the following standards. Has to be a bracelet or necklace, that's in statute, and it has to be inscribed with the declarant's name, declarant's date of birth, and then the actual words "do not resuscitate." And then the other part would be that it does state that in order to have the device, there should be an underlying document. And therefore, we are going to put in there that the actual vendor shall produce the DNR declaration. And therefore, if a provider relies upon this, they can reach out and ask and get a copy. I would note, I discussed with legal, we're going to put this in here. This is kind of a best practice. We don't really regulate the vendors, so I will caution that that is a challenge, but I think it's a good question. If someone asks you, can I get a DNR device? First of all, do you have a DNR? And if you do, then yes, you can go ahead and do it. And you can have that conversation. And then the final clause, C, is kind of that, start saying Good Samaritan, that's not accurate necessarily, but basically a clause that states if you reasonably rely upon it, then we aren't going to hold the clinician responsible. Because one of the questions that staff had was, well, what if it's a fake one? Well, unfortunately, it's a time-sensitive situation. If it appears to have the three items, then they should go with it.
So my plan, the DNR tattoo won't be.
Well, if it has those three categories.
Some states do recognize if people do that. It has to be a bracelet or necklace. So that is it. And so that is our request, is to adopt as a non-rural policy, clarifying do not resuscitate devices.
So moved. Second. Commissioner Hobby, motion, and seconded by Commissioner Bowman. Do we have any further discussion? Hearing none, let me call the roll.
Okay. Lee Turbin,
Aye.
Darren Hoggett,
Aye.
Dr. Clooney, Patrick Hutchison,
Aye.
Matt Shady,
Aye.
John Zarpin.
Aye.
Dr. Brown.
Aye.
Matt McCullough,
Aye.
Andrew Bowman,
Aye.
Mary Ann Dudley. Aye. Dr. Nassif,
Aye.
Lori Maley.
Aye.
And Dr. Yeagle.
Aye.
EMS leadership system.
So EMS leadership training, with that, we are doing, it began, it's been a challenge in Indiana. And when we did Indiana EMS 2025, that work group a couple of years ago, that was one of the key areas. And there was a recommendation in there that the IDHS, the EMS Commission shall or should adopt statewide training standards for our EMS leadership. That was a challenge because that document had so many recommendations. We have not been able to implement them in terms of like a bulk or a mass. And so we've kind of done them as they come up. And one of them that has gained traction has been this leadership concept. Commissioner Turpin has been looking at like more of a chiefs level training and trying to work on a little bit of a curriculum. And then from our staff, Jamie Thomas has been working on creating a kind of a field supervisor training. And so when we put the two together, then we said, you know, what are we looking for? You know, we feel like part of it may need to be virtual due to the nature of the size of the state. And then maybe the higher you go when you get to an executive leadership, it might be nice to have, like they have the Fire Chiefs Academy. And so we want to move that along. And in order to do that, then we need to look at the levels. So we probably have like a field supervisor, intermediate supervisor. We would have the executive officer and then some focus topics, you know. So yes, let's say we cover harassment and we go over what harassment is, most likely would be part of the content, but we can only squeeze in so much in these sessions. And so really like the field supervisor, it may be more of a teaser, like a 5 or 10 minute discussion, whereas you could certainly spend hours on it. And so that's what we mean by focus topics, try to produce things that people, and frankly, maybe present at Crossroads or the Fire Chiefs Conference on things like this that will help with the leadership background. So in order to do that, the next steps that we believe are, we are going to form a work group, and I kind of want to just update the commission where we are. I'm not asking for the commission to appoint in or otherwise, and there's a method to that madness. The reason that I'm not is initially, I don't believe this will be a mandatory requirement. And so therefore, we wouldn't be asking you to approve. And when it's approved at this level, then it is locked in stone. And as you know, these parts will be moving, and frankly, we'll probably do the first of any of these and realize, oh, this worked, this didn't work. And that gives us flexibility. So we'll continue to update the commission, but ultimately, you know, if we feel that it becomes mandatory at a certain level, that's when we would come back and say, here's what we have, and we would like you to approve it. But I think it's important to bring up to let you know we're working on it. And frankly, if you guys have ideas, reach out to me. And of course, the audience, both online and in person, if they have an interest, reach out, because we need good people on that work group to develop all levels. So that way we meet the needs of EMS leadership around the state. So with that, I'm open to any questions or comments or suggestions right now on this worthwhile project.
IDHS, mass casualty incident form.
This one's going to require no votes or anything either. So it's just, you guys all should have a copy of it, I believe, if you've gone over it. It basically, for mass casualty and our fatality plan, goes over the list of all the supporting agencies, goes over the purpose, scope, situation, and assumptions. It's all the aspects that you might think of on both of those plans, and then it goes over the agency and organization assignments. Jason Smith is our go-to for our staff person on this, working with our planning department within IDHS and many other agencies, as you'll see in there. So just an FYI, if you see something in there that you think should be changed, something added, something should come out of it, please send those to Jason and we will get that back to planning.
Okay, go on there. Hearing none, 2025 annual report.
Thank you to Robin and Jason for that. I know a lot of background work goes into putting that plan together, and it's important to kind of think through some of these items before something happens. Next, I'm pleased to present a overview for the commission and our attendees of the EMS annual report from 2025. This should be emailed out soon, and on our website, I just approved the messages for that. It takes a little while. One, we compile all the data in January, and then it takes public affairs, and I'm going to commend our public affairs section of IDHS. They are what helps make this report visually appealing. And so it certainly brings together a lot. You can look at, we build each year, we try to take suggestions. So if you have suggestions, but you can find out about like our IDHS engagement with other stakeholders, as well as there are commission updates. And honestly, because I can go through and I can ask Emily, we can search the old agendas, but like when it comes up, when did we approve the mandatory training for primary instructors? Sometimes the easiest for me is to go to the summaries that I put in here. And that's what I tell people. They're like, do you have a quick way? And I'm like, can you look at the annual report? Because, you know, it's a pretty brief synopsis and it's mostly things we voted on. So it's a great resource for you if you're looking for what has happened at commission meetings. We do have an update this year on the mandatory trainings. And you can see a little bit, we're slowly getting there with the mental health. We have the 3 trainings there. And then also on the traffic incident management. And so those statistics are in there. We are still a little low, you know, we're approaching a quarter compliance with that. So we still need to get the word out and make sure that people are getting those mandatory trainings. I'll pause and embarrass Robin a little bit, but I don't know if we, I asked staff to submit things and then I kind of hold this under wraps. So I put in a section thanking her. She has passed 40 years working for the state. She will usually tell people she started when she was 5, I think. But she does a great job with us and is such an asset. And so we had a special section in this one. We also do have our, if you're sometimes we get people that are confused. I get confused in our own agency, and we have an org chart. I have to figure out who is where. Ours has been pretty stable, but if you are wondering who falls where, you can see the org chart is there, as well as a nice picture of all of us when I try to remember who's missing, because of course it's the challenge of getting everyone together in one picture. We did threaten to print out people that aren't there and hold like little paddle signs with them. EMS readiness, we have a breakdown of that. I report on it at each commission meeting, but this is kind of what we're spending for 2025, or we have spent. AD grants was the biggest, but as you just learned, MIH grants was the next biggest. Test prep, though we spent a decent amount of money, it's actually a small part of our EMS readiness, and hopefully we'll get some good data back on that. And then the hand-heavy is the next largest one that we have. So that's kind of where that EMS readiness money is spending. And there's more of a broad description in the actual report. So feel free to go there and take a look at that. We do have our honorary numbers are there. You can see cardiac arrest save. Historic awards still continue to be the biggest that we have. I always pause in these presentations. When they edited, they took the pictures out. So I was a little bit saddened, but I did not push them, but I left them in for this presentation. But, you know, I wanted to pause to remember Larry Knuckles in January of last year. And then, of course, Bob Miller in October. And they were the 2 line of duty deaths. And so I always put it in here and pause for a minute to remember them. The other things we have in there are newly issued certifications. So you can see, of course, EMT is the most pursued and it is going to be at about half of it. But we have a good number of EMRs and of course, a decent number of paramedics. And then the total number of providers is a little bit similar, a little bit heavier on EMTs, but it has the breakdowns there and the percentage. So you can see that. When you look at long-term trending, you can see, and as I have used this grid, and so I always include it, and I started it, I think I go back, I traced it to 2015 numbers, and I have them still, but I don't include them. I just include the last 5 or 6 years. But you can see the good news is it's fairly stable. What's the bad news? Well, look at the run volume and look at, you know, the number of additional roles for EMS providers. So this doesn't totally tell the picture because it doesn't factor in needs. It is this base certification numbers that are out there. But the other positive that I seen last year, we were celebrating, we were over 25,000 for the first time in like a decade. Now we are still over 25,000 and still went up in numbers. So hopefully we can continue to grow that as we go forward. The retention rates are there. So if you're curious, the retention, the way we factor it is we look at the number of eligible certs, how many people are recertifying, as well as how many people are retiring, and plug in how many of the new people are coming in. So yeah, it factors all of those in terms of determining growth. We have our ambulance stats. So if you want to know there, provider organizations by type, and the largest is volunteer fire. That's not true for every state. The reason it's true for Indiana, and that's about half of our provider organization, is because we do regulate BLS non-transport. Other states do not regulate that, but because we do, that's why that's our largest number of providers. And then after that would be volunteer ambulance, hospital-based, government, and paid fire. Paid fire is actually the highest of them, but those are the different categories. Reporting, our reporting percentage ended up around 97%. Is a little bit of a challenge the past year, and I will pause and again thank Robin Stump. She supervises, I use the term supervises loosely because she's been having to do it for the past year with our EMS and fire data manager on a leave of absence. But the compliance is up there. We have 97%. So applaud her. I applaud the district staff that have been pushing their people to complete that data as well. But our incident numbers are there. Crept up around COVID, but it stayed up there. And so we had our highest year last year with 1,312,000 is where we ended up with. So 1.3 million, we had been at 1.2 for several years. So run volume still is up and there still is a demand that's out there. Then we also did include some data that Robin was able to pull with our data contractor, Monica, who does good things for us. And they were able to get average response times, scene times, and such. And so that is in the annual report if you would like to see those numbers to kind of compare to what's going on in your area. We have training statistics thanks to Carrie and her team. And you can see there the number of training institutions are 136 total right now. And we have a large number of ALS, which is good. And a good number of BLS. And of course, the ALS often are doing BLS as well. And then the number of courses we approved. We actually had we talked about modifying the practical exams. We actually had last year 175 exams. That was up from 157 the prior year. So we did have more EMT practicals going on. And then EMS division staff still helps out during peak periods to cover those if we cannot find one of the paid state representatives to do so. Tim is here today. I sing the praises, but Tim's doing a great job with the Sim Lab. It gets positive feedback and it's utilized very heavily. Sometimes it's hard to get scheduled in. Telling the story is the number of deployments. And I can remember back to 2019, 2020, when I became director, our chief financial officer would bug me because he would say, hey, we spend a lot on the Sim Lab and it's used like a third of the available weekdays. Why are we paying so much? Is there anything we can do? I worked to increase awareness of it, but frankly, Tim did a lot of the job of pursuing and encouraging people and explaining that it's a resource. And we really have to increase the number of deployments. And you can see with those deployments, we're also training a lot of people. So we have new equipment. We have a new Sim Lab itself. And so we have a lot to offer. But kudos to Tim, and there's information in the annual report there. So where can you find it, find these things? We will have it on the news section of our page, as well as we do have all of the other reports bookmarked in the EMS data section of our website. And so you can find them there if you would like to learn more. And should the email out, the link as well should be coming up anytime for all people that have an Acatus account. Yes.
Not to sound like a broken record, but can we look at for next year's report, incorporating men's club metric adherence, including light and siren response and transport?
We can try that. We have looked, and I'm hoping we can do that now. We have both. We will have a data manager, but we also, the agency has a data analyst. But the way it is reported in there was not an easy way to do those. So we have looked, but thank you for the reminder. We will continue to look now. We have a data analyst that may be more adept at compiling the individual answers. I think it's very possible. It's a great suggestion. Thank you. Other questions?
Okay. Updated EMS continuing education.
EMS continuing education forms are fun. That's a way of saying it. So we have the forms, and it still kills me, by the way. At my desk, I have a folder, continuing ed for 2027, because that's when mine's due. And I have my paper in there, and heaven forbid I lose my paper and have to redo that. So we're still working with Acatus, trying to get the online tracking more like the registry and more like the rest of the world in the 20th century. But in the meantime, we still have the forms. And so we do need the forms, because there is no way when we audit, we can just have you, and we do have people, hey, I got audited. Here's some JPEGs. Here's a few documents. Here's a few links. You can gather everything. Yeah. We need you to have it organized so we can verify you have everything you need. Whenever we update those forms, it becomes a challenge because we have to give time for people like me. So let's say we tried to say, let's switch it as of January 1st of 27. Well, I renew as of March 31st. So therefore, that means the form I have now is really outdated. So for the past almost a year now, I've been using it. So do I have to figure out how to transfer everything, or what form can I use? And so the process that we use is we actually will just make the new form mandatory 2 years from when we adopt it. And then we accept it, though, once we release it. So if you want to be proactive, and sometimes people do because the new forms are sometimes more streamlined, you can certainly do that. But if you say, I've already put a year into it, I'm not starting a new form, you can do that too. And so what Corey, and this was his suggestion, I applaud him on it, was he's like, let's start updating the forms to help track the mandatory training so people understand they need to do it. Because I know it's a surprise, but our emails don't always get read, telling people they have to do it. And I don't guarantee this will fix the problem. But it will catch some of the people will see and actually pay attention, realize they need to do those things. And so Corey has started the process of this. This is another one that will not need approval. It's more updating you. These are, the commission has delegated authority on this and says that on forms approved by the agency, the commission or IDHS should do this. So this is based upon the continuing education requirements. But we also are trying to plan ahead for what it will look like in 2 years. And so with that, I will let Corey kind of cover the overview, kind of what's coming, so that way then there's no surprises.
So the changes do not create any new requirement, change anything like that. One of the big things is we will accept their current national registry certification. So instead of completing the form and filling out all of the categories and all of that, you can attach the current national registry certification, but it does not cover your state components like your audit review and anything that the commission requires, specific state requirements. This is the place where the attachment for the current national registry certification would go. You would mark the box yes or no if that's what you're using. If someone is state certified only, they would still need to complete the form as normal and skip this part. This is the place showing the required mental health training and traffic incident management. It indicates that the mental health training is required every certification cycle. Traffic incident management is the one done, but it is their certificate. Your certificate of completion should be on your CADIS portal. Skills verification section has been updated for all certification levels. Instead of having everyone sign off every individual skill. This is the paramedic section. So the medical director or the training officer that's appointed by the medical director would sign, fill out the information verifying that their skills are complete.
Or are those skills still waived if you have something that's not affiliated?
So the inactive paramedic and advanced EMT is still the same. Yeah. This is the advanced EMT, similar to the paramedic. All the skills are the same. Nothing's changed. They've just been broke down different. EMT is the one that has remained the same. I just took out all of the extra space. This is because EMTs are not always affiliated, so they may have skills verification here or there. So that's good.
I want to thank Corey for capturing, because we had a discussion and I had encouraged him, the national registry is one of the biggest questions we get. Why do I have to fill it out here? Why do I have to fill it out here? So yeah, the continuing ed hours, absolutely acceptable. You'll just have to account for audit review.
Hey, Corey, if somebody's saying they don't get notifications of their certification being expired or going to be expired, what would be a reason for that?
They should be receiving those from CADIS. They're an automated email. So if they're using an organization email like their work email, it might get blocked by their firewall.
If they're using an old email from when they first started.
Yeah.
That's why
It's
they're not
important to
getting.
update your information in a CADIS because that's how we communicate. That's
We're back on the national registry thing where they check it. Do they upload the copy of the card then for verification?
Yep, it would be attached there.
Okay.
Yep.
Thank you.
And it would be, so if you expire the end of this month, your national registry certification that we would accept would be for the next 2 years, not the same expiration. Yeah, that makes sense.
So the registry would go as your new expiration.
Setting in,
The registry would be the new expiration for your license.
your expiration would stay the same unless we're changing your national registry, if that's what it is. But so if someone's national registry expires at the same time as their state, but they renew in their state, their national registry is expiring 3/31/26, we're not going to accept that one. We're going to accept the one that will be expiring 3/31. 28. That makes sense.
What about situations where there's gonna be an offset? A 3 month, 6 month, 9 month?
Same thing, we would do that. We can match their certs. If that's something that- yeah. Sometimes we have people that have national registry that is 1 year, and then their state is another year, they're doing something.
When can we expect this to go live?
It is over with our PIO department right now, so as soon as they do all of their color matching. all of it.
And we usually submit it to state forms because it has a state form number.
So on the registry, does have a state and or like local component for the two, you have like 10 hours for each or all that reviews not fit into those categories there.
So there are some, yes, their state component does cover some in the national registry, but for a paramedic to cert national registry, it's 60 hours, Indiana 72. So the additional hours will need to be documented on the state form. Does that make sense?
You can't, once you have your hours and then on the registry, it doesn't allow you to reassign.
And it's also a fluid process. So what we can anticipate is I ask them to kind of plan, but we don't have in the rural rewrite stuff. So it seems to be taking forever. But since one of the priorities of the current Braun administration is better efficiency, I'm hopeful that we are going to get some rural rewrite. And I think that would be part of it to make our hours match more parallel to the registries.
Yeah, so in the hours that Indiana requires already will cover national registry and national registry.
So.
Any other questions?
Good information.
All right, let me move on to old business, administrative proceedings.
Yes. The things I have there, just a couple of the waiver orders and the sanctions are in there. We did have one revocation you will see, and that is one of our appeals at the bottom. We did have the new action against Troy Delaney. And that was a complaint of violation of our probationary terms from his initial sanction. And that was resolved by agreement of the parties. And I believe that agreement is in the order folder there. The other matter that is still pending is Mike Masters. And that was a revocation with an appeal. And we have a hearing coming up, I believe either later this month or later this month.
The next up is the administrative rule.
No, nothing to report on that. That was one issue. I did not say.
Nothing. Forgot I opened Mike.
We have a data manager starting Monday. Ireland Straub will be our new EMS and fire data manager. She will be starting on Monday. I don't know if she's still online, but she was watching most of today. So excited to get her in, and she does not know fire and EMS. She knows data. I figured I don't know the data part of it, the technical side of that. We can teach her fire and EMS. So she starts Monday. We are very excited about that to get her up and going. Nearest is pretty much taken all of my life right now. Nearest and getting image trend updated. There are some things that we haven't been able to do because we're on an older version of image trend, working with our IT to do that and get that updated. So we did have an update this week. It didn't take care of all of the issues that I thought it was gonna take care of, so still working on that. So excited to bring Ireland in and have her help me with that. The biggest thing is, as of January 1, 2026, all fire incidents need to be on the nearest incident form. There's been a lot of departments that are still putting them on a NIFRS incident form, and those will not import to nearest. So as much as I put announcements on the image trend page when they log in, I can't make them read it. So I think Craig already went over the annual report numbers. I think we ended up with just over 753. A lot of fire incidents. Oh my goodness.
753,000.
For EMS, we're still working on version 3.5.1. Got a couple updates from NEMSIS on that will be taking place. And then did a new reporting for EMS. I had Monica go through because something caught my eye the other day when we were looking at things. And I had a provider still working on our 3.4 NEMSIS data set, and they should have been on 3.5 the middle of last year. So I had her put together a spreadsheet, and I found a very small handful of provider organizations that we quit getting data from all of a sudden. So, and they were large departments that we should have been getting a lot of information from. So I've reached out to those guys. We're getting that back in. We're back to 92% for EMS reporting. There's still some issues that we're having. The biggest thing that we have is when somebody changes software companies. I've got one right now that's moving from the paid version of ImageTrend, and a certain billing company, they're changing billing companies and moving to a different program software. If they don't tell us that, and I don't put them in that integration account, we then don't get any more data. So it's very important for all organizations to notify us if you're changing software vendors. I think that's it for data, unless there's any questions.
Great, then, any operations?
We are very close to having everything in Acadia for all organizations, vehicles, supervising hospitals, and training institutions. Stan is being very diligent with some lists that I'm giving him to make sure that everything's in there and up to date. For provider organizations, when you do your renewal in Acadia, it is very important to make sure that those 6 people are listed on your points of contact. The different surveys we've talked about today, the different things that we send out to provider organizations comes from that list. So we want to make sure that we're sending it to the right person for a survey or whatever we're asking for. It's coming from that list in Acadia. So we want to make sure that those provider organizations are getting that done. I don't know that the numbers at the end are still appropriate. I did this the beginning of the week for January 1, 2026 expiration date in Acadia. We still had 10 providers that were expired. For April 1, we still had 33 that were going to expire April 1st. So I'm sure that that's a little less, but they should all have an application in by now. If they don't.
Please don't mail them.
Please make sure to check your expiration dates and get a renewal application together. And that's it, I think that I have.
If someone, for example, is 6 months past doing their review on their provider information, and has changes to their roster, they should be either, is that notification, can they go in and change that themselves in case?
Yes, if they have permissions, they can go in and make changes to their roster automatically. If they don't have those permissions, there's a web form in Acadia, they can request that permission sheet. We're still doing the permissions sheet. Every once in a while, I still get a request from somebody, and I'm like, I don't think you're who is doing everything for that department. So if I know that there's another higher up person that does have permissions, then I'll email and say, hey, this person's requested and whatnot. So we're still asking for that permission sheet to be filled out per provider. I'm sure there was a lot of changes on January 1st with new chiefs and people coming in. So if they need to request that, there's a form that they can request that permission for. Anything else?
Ron? Bring it in. You can go on to certifications and compliance.
Certainly, we're not at the end of the quarter, so these numbers are not 100% accurate. So right now, in this quarter, we have more certified individuals than what we did in the fourth quarter of 25. We're over 26,000 providers right now. Of course, that's going to change at the end of the quarter because some people will expire, some will. So far, as of the 10th, we've done 114 audits. Quarter that says 0. There's actually 1. I'm sure those will change before the end of this quarter.
Circle, because I just signed one. I'm like, lies.
It will change. 47 individuals in this quarter so far have indicated that criminal record or notified us that were arrested or convicted. First quarter, 33 of those violations we've resolved. 5 we have waiting for more information. These numbers have changed already today. We have 6 hitting court, and then we have 3 scheduled for a 2-month period. Turnaround time for license and certification processing is still 24 hours. We'll admit, last week we did have a little bit of a delay, but everything's fine.
It's phenomenal.
I think that quarterly metric we do up to the first one following the net loss, net gain is really. It's kind of impressive. All last quarter.
And I continue to applaud the work of Corey and Jennifer. Because we were talking about yesterday, and I was having flashbacks to a few years ago when I was having to fix a lot of problems and spend a lot of time. And they really keep that part running very smooth.
Give us education and training report here.
So I did send out, yesterday, I sent out the invite for the April PI quarterly update. It's going to be April 7th. That's the morning session from 9 to 10 a.m. All the times are in Eastern Standard Time. And then the next day, Wednesday, the 8th, it'll be 5 to 6 p.m. And then attached to that invite, I did also send out the that schedule, that PowerPoint slide. So that way you can add a spot, save the date spot on your calendar. And I also put in there that I am going to send invites out as we get closer to those dates. So I didn't want to, once I start doing those, there's a tendency that I'm going to make mistakes. So I'd rather send them out one at a time like that. But at least you can mark it. And we do have got a couple guest speakers lined up, so hopefully that'll still work out. If anybody is interested in being a guest speaker, I'd love to have that. I'd love to focus on some different educational topics. So get a hold of me if you want to present, or if you maybe even want to just spotlight your education department. That would be wonderful. All right, so these are my, that's great. Okay, so National Registry, their site for several months now, and it all goes back to their big glitch that they had in July. Their performance reports, both for the training institution, programs, and for the states, has been down. Finally, it came up just in time for me to be able to put that into the our 2025 annual report. But I want to explain a couple of things. So this week, there's been a lot of discussion on the annual report, or not the annual report, but on the performance report. So when I ran this, at first, I accuracy wise, I think we're looking pretty good. There are some little glitches that they're still having, but the thing that state officials started noticing is that there were some variations, like when a training institution ran a report on a student compared to other students in their cohort, it wasn't adding up right. So what basically has happened is the report is pulling the information that it is required to do. There's no errors, but there is, you are a program director and you want to look at your program, there is next to the performance report, there's a little I, and that is, you click on that and it's going to give you the inclusion and the exclusions of this report. So it's important to look at that. That is the same. It hasn't changed since the glitch in the system. So it's pulling reports like they used to. But what the state officials, what we discovered at our Education Council meeting for NSIMSO, talking to National Registry, is that when, let's say a student takes an EMT course and goes through all 6 attempts and they fail and they have to take a new class. They take the new class, they successfully pass the class, and then they go and take their cognitive National Registry exam. They pass on the first attempt. So one would think that that second training institution that put them through the second course would get the credit for a first-time pass rate. No, it's not. And what happens is it's going back to whatever their very first program was that they took, it counts toward that. So technically, it's a 7th attempt in the National Registry system. This has nothing to do, it doesn't affect their number of attempts or anything with this new course. But when the state officials asked, why is this happening? They said, well, it's always been like that. I just, apparently now this is more under the microscope because of the glitch and the system being down. But the reason why they do it this way has to do with the statisticians that work at the National Registry and the way that they figure out numbers and do their research. And it basically goes back to the first time a student sees that particular test. So long story short, they are working on it. Hopefully it'll, they're gonna do some filters. Hopefully they're gonna be able to get this to where, you know, those attempts stay with that cohort. So I just wanted to throw that out there in case any rumors are going around, but they are working on that. So as you can see, our pass rate, I ran it from January 1st, 2025 to the end of December, 2025. And first I did first, third, and sixth. I figured why not? We'll make a nice chart and we'll put all 6 attempts in there. So overall, by the 6th attempt for the EMT level, we're at 76% and 84% compared to first attempt, which is 64% and 74%. So again, we like to see those EMT pass rates be up a little bit more. The next one is AEMT. AEMT usually stays about the same, although I felt like the first attempt pass rate was a little lower than usual at 59%, compared to the national is the one on in the orange. So just a little bit below. Third attempt, we're actually doing a little bit better than the national at 77% and 82% by the 6th attempt compared to national at 78%. Paramedic, we are at first time pass rate 69% compared to 73% national. Third attempt 84% compared to 87% national. So we're running pretty much where we usually do, just a couple percentages below national. And 6th attempt is 87% compared to 89% for the national. So looking pretty good. But again, hopefully, you know, I don't think we'll see drastic changes in numbers, but just in case you start running as a program director, you're running your own stats and you're like, wait a minute, you know, this isn't right. That's the explanation for that. Any questions about that? I know it's like clear as mud and we were all very confused.
Is that occurring with paramedic statistics as well?
Yes, all the statistics.
Because that becomes a co-a problem.
Yeah, and so they are aware of that. Nothing has changed, so keep doing what you're doing, but they are going to make that more user-friendly for the program directors and the state officials. So hopefully it'll make things look better. So, any other questions about that? All right, next slide is showing you our JV Learning student-driven prep codes. And just to remind everybody, we did have 2 sets of codes that we were offering for any classes that started after July 1st of 2025. We had the student-driven test prep code, which is more of an individual program the students did on their own. We also had an instructor-driven one. We were having a lot of issues with the instructor-driven one. There was just some communication differences, I think, between JV Learning and the instructors and getting additional codes, and it was just kind of a mess. So we talked to JV Learning and we converted those codes. I sent emails to anybody that had put in for the instructor codes saying that we are not having very good success with that. We converted all those remaining instructor codes to a student-driven side. So that gave us more codes to be able to issue. So as you can see from the graph here, originally we had, once we added the other codes in, we had 873 codes. No, we had 873. We had left 271 codes. So we still have some codes to go. And that I think included, I sent out several dozens yesterday. So I've been keeping up on that usually every other couple of days. But I am going to start going through. We're to the point now where I can go through and see which students have passed National Registry and on what attempts. We can start collecting some data, but that is going to be a little time consuming. Any questions on JV Learning? All right, so the PI mandatory training. Let's see. I made it all fancy here, so I wasn't sure what was coming up.
I think it's this review.
Okay, current U.S. Commission approved requirements of primary instructor, 12 hours of in-service continuing education. You had to attend one of the in-person education offerings in 2025. And then at the end of 2025, those instructors not compliant with the in-person requirement had to complete the CADIS online version. And they had until the end of the year to complete that. For those instructors that did not complete that by the end of the year, despite all the messaging we sent out in the newsletter, they have, after January 1st, they were marked as inactive in their CADIS portal, and they can't teach any courses until they complete that mandatory PI class on CADIS. And what will happen is if their renewal comes around for the primary instructor and they haven't completed it, then they're going to be marked as expired. So here you can see the graph. This goes back to 2000 to the beginning, January. And as of January, we had about 62% that did attend in person, and we had 21% did online, and back at the end of the year, beginning of January, 17% still had not completed it. And again, that just kind of describes timeline that as of February 1st, if they didn't complete it, we moved them to an inactive status. And this is as of just a couple days ago. We have 57 instructors that still need to complete it. So we got through almost everybody, but we still have a handful of people. I suspect that these people probably don't teach very much, and they're not really going to check in their emails, so we do still have some stragglers. Any questions for me about anything about education? Thank you very much.
Okay. State EMS Director's report, Director Kenny.
Thank you. The first thing to do I have is announcing for staff support. We recognized Robin. We have another recognition that we have. That is a happy 50th birthday to Dr. Yezel, and that is why he is virtual. He is celebrating that. So we wish him a happy birthday. Our next announcement doesn't involve old age. It involves our district forums that was referenced earlier. We are going to be offering this year. If you've never attended one, we do highlights over the past couple of years, and it also is a good time for back and forth. Like if you have questions, you can give us feedback. So we'll certainly be talking about EMS readiness. We're going to talk about education numbers. We'll be talking about all that stuff. So the schedule is on there. It's always local time, but start at 8:30. We will go to 11:50, and then we are going to allow a 10-minute update from emergency services from children. Margot will do those. And then fortunately, the EMS Association is supporting again this year, so they will provide a lunch. And then they will give a quick project overview of their initiatives for about 15 minutes. And then we will break out and have over an hour to do the breakout sessions. The breakout sessions are medical directors, including hospital medical direction, I should say. We don't always get medical directors, but that's what Dr. Yezel, where people can discuss things, diversion, whatever's on their mind. Second one is mobile integrated health. Third one is EMS education. The fourth one is pediatric emergency care coordinators, which is a second opportunity with Margot. So we encourage people to attend, but encourage your staff to attend, particularly if you have people in these categories, then it would be beneficial. But this will be going out as well, but here are the dates that we have. We have an ambitious schedule this year. We have a bunch of them. We have North, Northwest, Northeast. We will have one Central. We'll also have a second one that is an abbreviated version at the Fire Chiefs Conference. We'll do East, West, Southwest, and Southeast. So we will be getting around the state for several months beginning in May. And so those are great opportunities. So I encourage people to consider attending those and participating in those district forums. Again, we'll have more information. The EMS dispatch, I know Corey has a section in there about this, so you'll be able to find out more. The next fun topic I get to bring up is controlled substances. We have been talking about it for 5 years now. Board of Pharmacy adopted rules for Indiana's controlled substance registrations. We partnered with them to advise them what EMS was currently doing, what we could do. And so frankly, a lot of those rules should be easier for EMS to comply with. A lot of organizations listened to us and they obtained their Indiana CSR, which allowed them to get a DEA registration. All of this started with the 2017 Protecting Patient Access to Emergency Medications Act. And that act was basically transferring from your medical directors, transferring the controlled substances registrations to organizations since they were more directly responsible. And so the federal had a proposed rulemaking that started, I believe, in 21, went through a couple of notices, got a lot of feedback, and then was quiet for a long time. And then they suddenly announced their rule on February 6th and said it was effective on March 6th. So it is currently effective. So who's impacted is any EMS certified provider organization that carries controlled substances. And so if you are impacted, the one exception is if you are hospital owned and hospital operated, then they can operate under the hospitals. And so again, that's owned and operated. So I sometimes get a question, well, we contract. Once I hear the word contract, I'm like, no, that is not it. It physically is owned and operated by the hospital. If you are not exempt, then you need to obtain your state registration, which is the Controlled Substance Registration, CSR. If it is, and then that will lead to your DEA registration. And many people already hold these. Amen to you if you went out and got it done, because you're in good shape. I did hear, which made me feel a little better. I was on the CIMSO board meeting yesterday, and this came up as a topic from the Medical Directors Council. There are only 18 states that currently require EMS to obtain a state registration. And so if there's only 18, that means the rest of those states have to go through even their rulemaking before they can even get started. So our good news is we already have a state rule. We now know the federal rule. We just have to get the rest of the people over the finish line to do that. And so the options for transitioning are transition immediately. So if people are available, they can do that. They can transition at the expiration of the current registration, which would be under their medical director. So when that one expires, they can. And then I thought the next one was weird, and maybe I just don't understand how the registration works. Then they said the transition 3 to 6 months prior to a renewal. I wasn't, maybe they're encouraging you to do it so you don't hit the deadline. But in my mind, you either do it now or when you are due to renew, and anywhere in between is when you can't
Could
do
you
it.
go back one for just a second? Doc's trying to get a picture of your timeline.
And I think I accidentally hit it. It went on.
There you go.
And so those are the 3 options. And so I will say we have a little bit of a challenge before people here, and I'm sure there may be questions in the room or online. Before I get the question, we have a little bit of a hiccup with the Board of Pharmacy. They have not been communicating the best, and there is a backlog. So we know about that. The Indianapolis DEA office, I have not talked to the Northern DEA office, but they're usually very approachable as well. They are the northern third of Indiana. The Indianapolis covers, that office covers the rest of the state. And that office, they've been communicating very well. So they are not intending to come in, shut down, say, hey, you don't have your DEA, it's in your physician's name, you cannot carry controlled substances. That I don't want that panic factor going out. But yet they said we do need the people to start getting rule compliant. And I did explain to them there is a hiccup with the slow processing at the Board of Pharmacy. I did, without getting into too much, as I want to be respectful of another agency, I reached out, the Board of Pharmacy, the PLA, the licensure staff has changed literally. I think they're on like the 4th or 5th administration since I've been there. So I worked well with the initial rule people, and then when we implemented it, I worked well with them. They're all pretty much gone, and I could not get anyone to respond. And so with our chief of staff's approval, I reached out to the head of PLA and said, I really need someone to respond. And she responded late yesterday and said, they will be reaching out to you. Unfortunately, they have not reached out as of the time of this EMS commission. So I know they had a Board of Pharmacy meeting this week. And if we think ours are convoluted, sitting through those with the rulemaking, because they do hearings for anyone they take action on. And because they have so many nurses, physicians, pharmacists, it is a all-day thing that they do. So I know it does take time, but that's why we have not messaged from the state yet, is I'm waiting to hear from them if they can give any pointers, if they can give updates. We're going to try to get a list of who has a CSR and who needs it, so that our district managers can work with those that need it to kind of make sure that they are clear on that. I will give the caveat, it always makes me nervous, and when this came out again, I was like, I did my favorite quote, not my monkeys, not my circus, because it has absolutely nothing to do with IDHS. But we get a lot of providers that reach out because we represent the state or the state connection. So therefore, we want to facilitate communications with the Board of Pharmacy and between the EMS providers. And so that's why I'm covering the topic. So if you hear something slightly different and you're like, well, the DEA said this, I will probably say, they're talking about the federal rule, that's their rule, so it's their determination. But this is the best that I can take out of it. Essentially, again, it's moving from physicians to organizations. They have now added, when you first started, you had to do a weird, like there wasn't a good classification for EMS providers. Now they've actually created an ambulance service mid-level practitioner that you can apply for with the DEA part of it. Clarifies licensed persons may carry, administer within their scope of practice, and then a single registration per state per organization. So if you are a larger organization that operates different, and I'm thinking like a TransCare or someone like that, that has different regional offices, then they still just need one CSR and then one DEA, and then they will list the remote locations that they operate instead of having to obtain like 8 or 9. So that's a positive because you only need the one. And again, an EMS organization owned and operated by a hospital is not in this. I was jumping ahead a little. They call it a station house in the actual federal rulemaking. But the concept is, where you have the outline, you have a headquarters and the outline. So the headquarters concept is always going to be the one where you store your controlled substances and it has to be secured. And you can't just have it on like a movable vault or anything. So that is the one that you register, and then you can operate with your station houses wherever they are. And then they give you guidance on those station houses. And it's kind of weird. You register them and then you have like 30 days and then you can operate out of them. And they have 30 days to kind of object. If they're like, we don't feel like this is appropriate, then they can tell you that. But that's kind of how they're going to do it. Record keeping seems very similar for that. I do have the tracking things down there, but I really do feel like most organizations are probably following this because of the structure the medical director set up. So hopefully it's not a big change in record keeping for anyone. Security is very similar. I will say the one thing that I've grown down is like, I know, and I think an organization could have a tighter rule. We would never allow, but they say you can carry it on your person if you're on a response. On ours, you always take a locked box and have at least one locked box. So if you set it down or otherwise, as I did have an employee once that went, they had to take her on an ATV and then she said it bounced out of her pocket. Well, that's kind of a logistics nightmare, to investigate where that went. But you can look at it, your organization decide what's appropriate. But the DEA says if they're on a response, they can have them on there. Also addresses when vehicles are locked and unlocked. The good news is if it's in your secure bay and stuff, you don't lock the doors of the ambulance. But if you are off site, like let's say you're doing a football game or something, then it is supposed to be locked if you are not in the vehicle. Then the vehicle itself is supposed to be locked. You do not have to have it locked on emergency scene. And then if persons are present, then you would not have to have it locked. So if you're just sitting there in the vehicle or even in the back, then you would not have to have it. So those are kind of the highlights of that. Again, we will send out some messaging as we hear from Board of Pharmacy and I get a little more direction on their timeline. I do want to clarify the DEA did say one thing. They said, we know people are anxious. If you do not have your Indiana CSR, do not apply for a DEA registration because it progresses. And what will happen is it'll progress and it gets to a point where they will verify. And if you don't have it, it'll kick it out of the system and then you have to reapply. So they said, please encourage people not to jump the gun, wait till they get their Indiana CSR and then apply. With that, I will pause and see if there's any questions on this kind of pivotal topic. Again, I knew we had impacts here in Indiana, but when I was listening on the SIMSO, I'm like, oh, we're kind of ahead of the curve, so that's a good thing. The next thing I have on my report, we have Crossroads Conference, and as you heard, they're planning for 2026. They're looking for speakers. I did want to cover that one of the commissions of the EMS Commission is to sponsor and organize a conference, and we don't always talk about it. And I just wanted to highlight and make sure there was no objection. And with the sponsor, we have EMS readiness money, which funnels through IDHS side, not the commission side. But we have been using that to sponsor the EMS Association conference. And the Braun administration has shifted away from sponsoring in conferences, but we did get approval based on the statute that we were facilitating the EMS Commission in meeting a statutory duty. And so if anyone has any concerns, please express them. But our plan would be for this year to sponsor pre-conference and main conference. And part of that, we make sure it meets certain parameters, like having the mobile integrated health in there, some workforce content, things of that nature. Health First updates. We are in fiscal year 25 to 26, so we had 4.1 million. You saw a little bit of the breakdown. A couple of announcements. I had announced that we had the AED grants for BLS non-transport. Just a few final numbers out of there, 164 approved applications, and we awarded 410,000 to get AEDs for the BLS non-transports that apply around the state. We also then had money left over and had additional funding, and we frankly are looking at issuing around $1 million total for an additional round of mobile integrated health. We did pass the application period. We asked for got the basic information we've used in the past, and that does include the expanded language of the commission grant, although it's not funded, where we do accept for any EMS certified provider organization. So that can be fire-based, that can also be private EMS, that can be hospital-based, that can be county-based. Pretty much if you are an approved program, we have considered you for that. So we had 32, we found that 4 were ineligible for different reasons, and 28 programs were awarded. We don't have the list because we're in the middle of sending them out. But again, it's going to be roughly around $1 million funding MIH on this round. So we're very excited to be able to do that. And there are a lot of innovative programs submitted for that. EMS and Grow, that is a fun topic. I looked to see if I put Corey in seizures. He's been kind of my wingman on all this, and we get drug in like meetings almost daily with it. So we have 4 connections on the MOP concept. Dr. Gazel is our lead. He's been advising Department of Health, and that will be to create a medical operations center that can kind of both assist with facilitating inter-facility transfers, but potentially even scene response, say for like mental health, to maybe connect that with the right receiving facility. Initiative 3 is improving interoperability in the patient health records and to incorporate EMS records into that, but also allow EMS and MIH to pull that information so that we'd like it to the point where a provider can log on. If you have patient X, you can find patient X record and see what they were treated for and communicate with that physician. And so with that part, we also have MIH interoperability and a data platform, and we're getting very close thanks to Corey's hard work working with Emily and I. The 3 of us hammered out, and I'm hoping we can have an announcement on a data platform that we'll be able to collect data. But he successfully submitted, that's the one we got voluntold for the rest. This is the one section that Corey wrote up and applied for, did a great job. And we will be adding contractors that will facilitate MIH and MIH data so that they'll be more than asking for Emily to try to extend her some statewide. And so with that, we hope to have more announcements. We're getting closer to adding staffing. As I said, I think we're close on the data platform and where we need to be. Initiative 4 then is pediatric OB readiness. I thought it was interesting, Commissioner Bowman's comment earlier for Benton County, and I think that is an opportunity, is that we're going to see a pediatric and maternity readiness program that goes through there. And we are partnering with IU, Emergency Services for Children. IDOH is leading that angle. IDHS EMS is involved. And we are doing the pediatric readiness in the EMS environment, the pre-hospital. And so we will be conducting in year 1 a survey of the readiness that'll be similar to the national one, but what we're going to take is some of theirs and apply some of our Indiana and take a deeper look. And kind of my vision, because I know that Margot would agree because we communicate a lot, it's challenging to get people to fill out the survey, and then we hope that the best person with the best information is doing it, and that's not always the case. And so what my hope is that we can actually go out and send people, because I think we have the funding to physically sit down with you and say, do you have a PEC coordinator? What's the PEC coordinator doing? Are you doing this type of training? Do you have this equipment? And so I think it's going to be a little more engaged than the ones that we've done in the past. But the grant affords us that opportunity. And then ultimately that will become a sub-grant in future years where we will be able to work with Emergency Services for Children and say, this is our goal for every organization to have OB, maternity, peds readiness. And if you apply, you can get approval for these things, and we have funding to assist you to get there. So I think there's a lot of opportunity in that section. And I do think MIH is one that could really benefit and also help provide services in that area. Initiative 12, we are not directly in, but I bring up every time. Again, they finally had their interest meetings. There are the different regions that are on the GROW website. If you want to know more, just type in Indiana GROW, and it's the first hit there, and you can read up and see the regions. But they are getting ready to set up their system for doing the regional grants. And EMS is very eligible, but they want it as a regional approach. So if you as an individual provider apply, you're less likely to be considered if you are not part of your region. So you need to be at the table advocating that you're included in that application, kind of like EMS did at the state level. They're kind of duplicating what we did with our federal application. So there's actually the map, do have that. And so there are some shaded areas. I still give my hats off to Vanderburgh County because I have no idea how they manage the rural one. But whereas like Bloomington and Monroe are knocked out of it. But this is the map that they went with. And so if you are in white, you are not eligible for any of that district funding. I do think there are benefits for every EMS provider. For instance, the interoperability piece, obviously I can't envision that we turn that on and say, sorry, you're in an urban area, you can't access that. I feel like that project's going to be an all or nothing, which will impact everyone positively. EMS Compact continues to update. We do have several states that are working and considering, including Ohio and Kentucky around us. And Illinois just announced that they are doing a big push. And so we may end up seeing the states around. Michigan is not eligible. She would groan if she was here because she's not happy about it. That has to do with legislative enactment that said that they don't have to use the National Registry and requires their state to develop their own test. And the actual statute for the compact says you have to use National Registry to determine initial competency. And so they are not eligible, so they would not be joining the compact. Data on the compact, I am pleased to announce, we sent out an announcement, but we are putting data in. It's a little bit, the best way I can describe it is we have our bucket Nikitas, and they've created a pipeline into the NIMSKID database, and it doesn't directly connect to our current bucket. So we're gradually moving everything into the pipeline, which creates that connectivity. So yes, we are connected, we are successful, we're compliant, but if you look up your name, you may or may not have compact privileges as we look to get everyone integrated. If you need them for some reason, or you're just pushy, then you can get a hold of us and we can add you into that. I've added some people, I added a few of the commission members in there. So there are people that are in there if you would like to check. If you just want to see if it works, then you find someone. I know my name was entered and I am in there, and you can verify that. This is not that I'm planning to leave, where everyone says, oh, he's planning to leave. That's why it's. The SIMSA National Association of State EMS officials, we continue to still be very engaged in that. And a lot of the committees, I know the Education Council, Carrie does great work with them. We also have Rural Health, Jason doing, Corey's on the licensure ones, and then Robin is on the vehicle and agency one. And so, and data. And so those very engaged, and that's the one I'm president-elect. We have the annual meeting at the end of April, so I'll be reporting back any changes there. But we are going to Kansas City this year. A point of topic is next year, when I will move from president-elect to president. We're actually not sure how we decided this, but we're going to Anchorage next year. So that's going to be quite the hike to get up there. Yeah. EMS commission date. So as Lee usually announces, chairperson announces at the end, we will be back here for our May meeting, but that's just the rest of the MIH and EMS commission meetings. With that, I'm open to any questions that anyone. Sorry, a lot of material. I started with not much, but like the DA one took a while.
Any questions for any EMS medical directors report, Dr. Gazer?
Hey, everybody. Sorry I couldn't be there in person. I wish I could say the 50th birthday festivities had already begun, but I'm actually out in DC for a National Overdose Policy Forum representing EMS. Had some cool chances to talk about what we're doing in Indiana and learn some things from our other states. So it's been a good time. The birthday festivities will start tomorrow. I guess that at 50 involves nursing home placement and whatnot. So we'll see how that goes. Not much to add on the rural health transformation stuff. The one thing I will say is I know we encouraged a lot of you to apply for your regional coalitions, and those steering committees supposedly will be announced today. And also, if you weren't selected, you'll be notified as well. I've gotten a lot of questions over when that'll happen. So they just kind of serve as the guidance to those coalitions. So if you weren't selected, still get out there to those, because there's a lot of money, like Craig said, being funded through theirs, and EMS initiatives are high priority. So really, really encourage that. On the whole blood front, we are up to, I believe, 13, maybe 14 programs statewide, and starting to see some enhanced collaboration on working with adjacent services to make those blood products go farther. So exciting times there. I know we have several others that are very close to launching as well. So really, really exciting time there. Along the training front, I want to mention, just for your visibility and because if there's interest elsewhere, we had a really, really successful HALO procedure training event in Johnson County in February. 3 days, and by HALO, high acuity, low occurrence procedures, where we had cadavers, we did Crikes, chest tubes, had a very realistic maternal C-section model that we did. and the feedback from the services was outstanding. I do know that there's some works looking at Harrison County coming up, and if you'd like it in your area, please reach out. I think there's some opportunities there. Like I said, I think it was very beneficial for our crews. I know Commissioner Bowman was there. I don't know if you have anything to add on that or any thoughts.
So as you mentioned, February 3rd, 4th, and 5th, under the direction of Dr. Alan Parton, who's one of my colleagues with my emergency medicine group, who's the medical director for Johnson County EMS. We hosted a 3-day cadaver lab payload field session. Approximately 85 participants were there from Greenwood Fire, White River Township Fire, Bargersville Fire, and Edinburgh Fire. Hands-on training from several expert instructors, Dr. Yazel and Dr. Barton included, as well as Dr. Tim Pullman, a trauma surgeon, covered in quick summary, basic advanced airway on both mannequins and human cadavers, direct and video laryngoscopy on mannequins and human cadavers, surgical crite using the scalpel finger Fuji technique on human cadavers, extremity tourniquet and amputation on human cadavers and animal legs, needle decompression, finger thoracostomy, OB emergencies, again with a very well created resuscitative hysterotomy model by the team in St. Francis, Josie Harrell and Amanda Gill. And then Dr. Pullman led a interactive thoracotomy station to educate on chest anatomy and trauma resuscitation skills. So they very well put together and well attended program.
Yeah, I totally agree. Like I said, it was one of the best run and most beneficial education programs I've been around in my 20 years of doing this. So yeah, thanks to all that helped set it up, all that volunteered their time, and also all the students that were invested and engaged. And again, would love to replicate this model around the state. So if you're interested, please reach out, because I think there's some mechanisms to get that done. Really, the only other thing I have is, where there's a lot of talk about diversion and how we're going to go away from crowding-based diversion. And I think we are ready to. We've been kind of circulating that there's a consensus on that, but I think you're going to see a formal announcement from some state leadership coming up, and basically that's going to encourage, again, stressing the point that this is crowding-based, that you still are allowed some diversion for internal disaster type things, and then also fostering communication between our services and our emergency departments about crowding and things like that, transparent conversations and things. So looking forward to that and seeing that, because I think that'll be a huge a benefit to some of our services that encounter that day in, day out. So other than that, nothing huge from my end. Open to any questions, and otherwise, again, sorry I couldn't be there in person, and look forward to catching up to everybody at the next meeting. So.
Any questions for Dr. Yazel? Okay, moving on to Chairman's report and direction.
I got you.
The only thing I would make note of, some of my items have already been covered, so to not extend the meeting any longer than necessary. One thing I would call attention to is the U.S. Metropolitan Medical Records Consortium meeting. The Eagles registration is out for that for June. They are changing the location. It's still in the general area of Fort Lauderdale, but the registration information is available on their website. The next meeting of the commission is Friday, May 8th, 2026 at 10 a.m. Eastern Time at May here in Plainfield, where we are today. And I will entertain a motion to adjourn.